Good morning, everyone. We do expect to get started on time in about 5 minutes. In the meantime, I've dropped some technical information you might find helpful in the chat panel. Thank you. Good morning, everyone. I'm Leanne Griffin, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Recovery Planning and Sustainability. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. As an attendee, you are in listen-only mode and will only be able to view your own name. If you have questions, please send them to the presenter and me, I'm the host, by using the Q&A panel. Please use the Q&A panel to send any questions you may have today, and the presenter will address them as time permits. Our audio is being broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now. These options are also posted in the chat panel. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the I will call in option. You must be connected to the audio portion of the presentation and view it on screen to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FATA website within 5 business days. Also, a PDF version of the PowerPoint presentation will be emailed to participants within that same time frame. FATA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation on the FATA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FATA as part of registering remains confidential. Statements of credit will be posted within 5 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive continuing education credits or to access your statement of credit. Please do note that the evaluation will close at midnight on Friday, December the 7th. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you do not need to provide your certification number when you register with our site. Also, do note that WebEx monitors arrival and departure of attendees and provides us with a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar, and we're not permitted to provide partial credit. Dean LeMire is an adjunct faculty member with the National Recovery Institute. Dean is a person in long-term recovery and a New Hampshire native who has served in roles touching several disciplines of substance use disorder care. As former director of a recovery community organization and founder of a syringe services program, Dean has experience in building effective, person-centered recovery supports that are responsive to the complex nature of addiction and of recovery. And we're very pleased to have Dean join us today. And Jean, if you're ready, I'm going to bring up your presentation and then turn control of the webinar over to you.
Okay, great. Well, hi everyone, and thanks Leanne for introducing me. And thanks for everyone for joining in. This is definitely a topic that I'm passionate about, and I encourage your questions and your comments during the webinar using the Q&A panel. I would have screwed up and used the chat panel, so let's use the Q&A panel. And you know, what we're going to talk about is a moving target and a puzzle with a lot of pieces. There's, you know, if there's a true expert in how to approach perfect care for all people with substance use disorders, I want to meet him or her. And in the meantime, it's discussions like this one and almost daily revising of our practices and belief systems that will move the needle. So again, thank you for joining me in exploring this topic. So we will start with technical difficulties.
That's all right, Dean. Do remember that you need to use your mouse and click inside the center pane to activate it, and that should work.
Right, I see it. Okay, sorry everyone. So we'll go over the learning objectives for today. You should be able to, by the end of this, describe differences between and strategies for transitioning from an acute model of substance use to a chronic and recovery-oriented model of care. You should be able to describe why and how we can shift power in achieving recovery goals from provider to the individual. And you should be able to describe recovery wellness planning as delivered by peer professionals and incorporated into provided collaboratively or provided in lieu of clinical care. So we'll start really basic. This is how someone in a recovery coach academy starts day one of their training. What is recovery from substance use disorders and mental health disorders? So I'd like you to type in the chat panel, or the Q&A panel with your answer, and just let it be your own definition or wording, and I'll give you about a minute to complete this.
And Dean, this is Leanne. Can you repeat your inquiry?
What is recovery from substance use disorders and mental health disorders?
Thank you. And we can give this another minute or two if people would like to respond. And we are seeing some answers in the Q&A panel. Dean, are you seeing those as well?
I am, yeah. In a few seconds, I'll start reading some of them.
Perfect, thank you.
So I'm seeing some pretty varied answers. Can everybody else see each other's answers?
No, Dean, only you and I can see everyone's answers.
Okay. So I won't attribute some of these responses to the individuals, but I've got one. Says improved ability to function effectively in home, family, and social situations. Another, clean and sober living. Recovery is returning to a healing point without the use of substances. Change in lifestyle and behaviors to support goals of overall improved well-being. Sustained sobriety through change of thought and perception of life through a 12-step program or mental health assessment. Recovery is maintained sobriety and stable living conditions. So there's quite a variety of answers here. And not by way of giving you the answer, but here's one answer that was the product of hundreds of people by, work group and reaching out to stakeholders that was facilitated by SAMHSA between 2010 and 2012. And this will be a primer for some and a reminder for others. A process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And that's a pretty broad and inclusive definition, right? It doesn't touch pathology, symptom management, timelines. This changed from earlier definitions that made mention of abstinence from substance use. And even with this new definition, I've heard criticism like, you don't ask Joe in accounting to strive for his full potential in a doctor's visit about his diabetes. But the purpose of starting this way is to show that there are many different and valid conceptions about what constitutes recovery. And this is obviously a definition built by committee. So that same effort convened by SAMHSA and released in 2012 produced 4 major dimensions of a life in recovery. Health, which can be described as overcoming or managing one's diseases or symptoms and making informed, healthy choices that support physical and emotional well-being. Home, a stable place to live that is also safe. Purpose, meaningful daily activities such as a job, school, volunteerism, family caretaking, or creative endeavors, and the independence, income, and resources to participate in society. And community, relationships and social networks that provide support, friendship, love, and hope. And SAMHSA has since collected input and released 8 dimensions of wellness known to influence the mental and physical health of any one of us. The first is emotional, coping effectively with life and creating satisfying relationships. Environmental, good health by occupying pleasant, stimulating environments that support well-being. Financial, satisfaction with current and future financial situations. Intellectual, recognizing creative abilities and finding ways to expand knowledge and skills. Occupational, personal satisfaction and enrichment from one's work. Physical, recognizing the need for physical activity, healthy foods, and sleep. Social, developing a sense of connection, belonging, and well-developed support system. And spiritual, expanding a sense of purpose and meaning in life. So back to that 2012 recovery definition project, that effort also produced 10 guiding principles of recovery. And we can think of these principles as promoting social justice relative to treatment of and for people with substance use disorders and mental health disorders. And we can also think of them as universal truths to inform our service delivery. I'll read each one with explanations, and bear with me, I'll stop talking eventually. So the first is, recovery emerges from hope. The belief that recovery is real provides the essential and motivating message of a better future, that people can and do overcome internal and external challenges, barriers, and obstacles that confront them. Hope is internalized and can be fostered by peers, family, providers, allies, and others. Hope is the catalyst of the recovery process. The principle that recovery is person-driven. Self-determination and self-direction are the foundations for recovery as individuals define their own life goals and design their own unique paths toward those goals. Individuals optimize their autonomy and independence to the greatest extent possible by leading, controlling, and exercising choice over the services and supports that assist their recovery and resilience. In so doing, they are empowered and provided the resources to make informed decisions, initiate recovery, build on their strengths, and gain or regain control over their lives. Recovery occurs via many pathways. Individuals are unique with distinct needs, strengths, preferences, goals, culture, and backgrounds, including trauma experiences that affect and determine their pathways to recovery. Recovery is built on the multiple capacities, strengths, talents, coping abilities, resources, and inherent value of each individual. Recovery pathways are highly personalized. They may include professional clinical treatment, use of medications, support from families and in schools, faith-based approaches, peer support, and other approaches. Recovery is nonlinear, characterized by continual growth and improved functioning that may involve setbacks. Because setbacks are a natural, though not inevitable, part of the recovery process, it is essential to foster resilience for all individuals and families. Abstinence from the use of alcohol, illicit drugs, and non-prescribed medications is the goal for those with addiction. Use of tobacco and non-prescribed or illicit drugs is not safe for anyone. In some cases, recovery pathways can be enabled by creating a supportive environment. This is especially true for children who may not have the legal or developmental capacity to set their own course. Recovery is holistic. Recovery encompasses an individual's whole life, including mind, body, spirit, and community. This includes addressing self-care practices, family, housing, employment, education, clinical treatment for mental disorders and substance use disorders, services and supports, primary health care, dental care, complementary and alternative services, faith, spirituality, creativity, social networks, transportation, and community participation. The array of services and supports available should be integrated and coordinated. Recovery is supported by peers and allies. Mutual support and mutual aid groups, including the sharing of experiential knowledge and skills, as well as social learning, play an invaluable role in recovery. Peers encourage other peers to provide each other with a vital sense of belonging, supportive relationships, valued roles, and community. Through helping others and giving back to the community, one helps oneself. Peer-operated supports and services provide important resources to assist people along their journeys of recovery and wellness. Professionals can also play an important role in the recovery process by providing clinical treatment and other services that support individuals in their chosen recovery path. While peers and allies play an important role for many in recovery, their role for children and youth may be slightly different. Peer supports for families are very important for children with behavioral health problems and can play a supportive role for youth in recovery. Recovery is supported through relationships and social networks. An important factor in the recovery process is the presence and involvement of people who believe in the person's ability to recover, who offer hope, support, and encouragement, and who also suggest strategies and resources for change. Family members, peers, providers, faith groups, community members, and other allies form vital support networks. Through these relationships, people leave unhealthy and or unfulfilling life roles behind and engage in new roles like partner, caregiver, friend, student, employee that lead to a greater sense of belonging, personhood, empowerment, autonomy, social inclusion, and community participation. Number 8 is recovery is culturally based in influence. Culture and cultural backgrounds in all of its diverse representations, including values, traditions, and beliefs, are keys in determining a person's journey and unique pathway to recovery. Services should be culturally grounded, attuned, sensitive, congruent, and competent, as well as personalized to meet each individual's unique needs. Recovery is supported by addressing trauma. The experience of trauma, such as physical or sexual abuse, domestic violence, war, disaster, and others, is often a precursor to or associated with alcohol and drug use, mental health problems, and related issues. Services and supports should be trauma-informed to foster safety, like physical and emotional safety, and trust, as well as promote choice, empowerment, and collaboration. Recovery involves individual, family, and community strengths and responsibility. Individuals, families, and communities have strengths and resources that serve as a foundation for recovery. In addition, individuals have a personal responsibility for their own self-care and journeys of recovery. Individuals should be supported in speaking for themselves. Families and significant others have responsibilities to support their loved ones, especially for children and youth in recovery. Communities have responsibilities to provide opportunities and resources to address discrimination and to foster social inclusion and recovery. Individuals in recovery also have a social responsibility and should have the ability to join with peers to speak collectively about their strengths, needs, wants, desires, and aspirations. Got one more. Recovery is based on respect. Communities, systems, and societal acceptance and appreciation for people affected by mental health and substance use problems, including protecting their rights and eliminating discrimination, are crucial in achieving recovery. There is a need to acknowledge that taking steps back toward recovery may require great courage. Self-acceptance, developing a positive and meaningful sense of identity, and regaining belief in oneself are particularly important. So 10 principles guiding recovery and recovery services. So William White, our most prolific and trusted addiction, treatment, and recovery historian and researcher, said of substance use recovery that a growing number of studies confirm that recovery begins prior to cessation of drug use, is marked in its earliest stages by extreme ambivalence, is influenced by age, gender, and culture-mediated change processes, involves predictable stages, processes, and levels of change, and that those factors that maintain recovery are different than the factors that initiate recovery. So a little bit about that. Excuse me, I'm going to take a drink of water. That was a lot of reading. Less reading now. So a little bit about that predictable stages piece from the last slide. The trans-theoretical model of change charts common stages that people experience relative to recovery. I have noted that the appropriate supports and interventions that match each stage, that these are not comprehensive lists, they're pretty basic. For me, it was about 10 years living with severe alcohol and heroin use disorders before I landed in the action stage of my recovery. And my first action was to seek treatment. So I know my experience is pretty common. And I think about how my addiction career could have been shortened by stage-appropriate interventions. And now I'll turn it over to you all again. So after we've just covered about the fundamentals of recovery, how do our services and systems fit? So you can throw your comments in the Q&A box. Any thoughts that you have after reflecting on questions 1 and 2, and I'll give you a little less than a minute. So once again, we're just answering 1 or 2 and putting your thoughts into the Q&A box. So I'll start reading some of the responses while others enter theirs. Yes to those questions. There are strong efforts to promote recovery-oriented system, but payers and funding sources are by nature illness-based. Another one, many in the field still embrace an old school philosophy from many, many years ago and take a more punitive approach rather than a person-centered, supportive, and empowerment approach. Yes and no. I come from 20 years in recovery and 18 in the industry, and more progressive systems match our new definitions, but many still adhere to the old ways of abstinence only. Another answer, fragmented treatment and clinical influence, not person-centered or recovery-oriented for most. More as treatment done to a person versus treatment that collaborates with the person and has the person as the driver of care. More expert to the consumer model. And acute model versus chronic model. These are some good answers. Well, thank you very much. Now let's consider question 3. What improvements could be made? And this could take us, into the weekend, but I'll just read some of your early comments in a minute. What improvements could be made to our systems and services upon reflecting on the recovery principles, elements, and definition that we just covered? There's an early one. I could work on my spelling and typing.
Oh, that's funny.
More housing first, acceptance of the person as the driver of care. Listening to those receiving treatment, focusing on the person's needs to necessarily just the treatment. Probably reading that wrong. Improvements would be public funding and education. Higher focus on certified peer support. The historical model of care, in my opinion, is outdated because of the changes in society, so does the manner in which we approach recovery. Being more open-minded to different models of care gives us more tools to help others. Increased understanding and acceptance of harm reduction models. Recovery needs to be viewed on a continuum versus an end destination by all key stakeholders. So these are some great comments, and thank you for them. There are a lot of criticisms to note regarding needed improvements to our systems of care. And one common criticism that some of you all have already touched on is that we tend to provide acute care services for chronic conditions. And we can see what a small role acute care services play in the recovery for an individual, where their recovery, may last a lifetime, certainly more than, 28 days or 7 days. And in fact, we can imagine how harmful such a model can be to recovery outcomes, including consumer opinion of our services, when we don't offer whole health services when they're needed and for as long as they're needed. If an acute model of care hopes to tackle, what do we cover? 4 dimensions of recovery and push patients through stages of change up to maintenance of 8 known dimensions of wellness. Systems and providers under such a model have a tough row ahead. So some characteristics of an acute care model are crisis-linked points of intervention. So services are offered at the point that somebody, is in crisis and not before. There's a brief duration of care, singular focus on symptom suppression, and especially on abstinence, professionally dominated decision-making processes, short service relationship, expectation of full and permanent problem resolution following discharge or graduation. And, some of the reasons that that model sustains is, and where it came from is high medicalization and professionalization and commercialization of care for folks like me. Some of you touched on the funders and funding mechanisms, the repayment models for this kind of care. Federal and state regulations can often be more harmful than helpful. And there's a siloing effect that I think most of us have probably complained about over the last 10 years, and that may be getting better in your community, but overall, our services are still largely siloed and don't interact with each other or learn from each other very much. Who has heard about recovery-oriented system of care? Show of hands. Well, that's what we're going to talk about in case you haven't heard about it. So a definition of a recovery-oriented system of care is a coordinated network of community-based services and supports that is person-centered and builds on the strengths and resilience of individuals, families, and communities to achieve abstinence and improved health, wellness, and quality of life for those with or at risk of alcohol and other drug problems. I recently got an update from William White on his thinking about recovery outcomes. Well, I'll actually share that in the next slide. So some of the characteristics of a recovery-oriented system of care are that is a chronic versus acute care model. It's easy to navigate for individuals seeking care. It's transparent in its operations, responsive to cultural diversity, includes longer-term outpatient care, recovery housing, recovery coaching, and aftercare checkups, not just for the first 3 months, but for much longer. And treatment providers act in partnership and in a consultation role with patients, participants, and draw upon individual goals, strengths, family supports, and community resources. So a recovery-oriented system care is outcomes-driven. The individual outcomes can be abstinence, including adherence to a medication-assisted recovery regimen, whether they continue or begin their formal education, their employability and employment, reduced criminal justice involvement, stability in housing, improved health, social connectedness, and quality of life. And outcomes for systems within a ROSC are increased access and capacity for individuals, proper placement and quality of care, retention, perception of care, cost effectiveness, and use of evidence-based practices. So I hit William White up recently to clarify some points about his conceptions of a recovery-oriented system of care, and particularly the individual outcomes. And he said that he thinks of them now as 3 areas of focus. One, which is the resolution of drug-related problems, which is usually historically measured by continuing abstinence or diagnostic remission. And diagnostic remission, which he favors now, leaves open the possible alternative of successful and sustained deceleration of use, particularly for those with lower problem severity and greater recovery capital. So we're talking about this abstinence piece, where that historically has been the main focus, but with a new understanding that is much more broad about the health of a person and what is helpful in achieving health outcomes, abstinence is playing a smaller role. William White also thinks of individual recovery outcomes under our ROSC as enhancement of global health and functioning and healing of the person-community relationship. So even the experts disagree with themselves over time, as they should. So a ROSC framework represents a paradigm shift. And put simply, a ROSC will stop asking, how do we get this person into treatment? And we'll start asking, how do we nest the process of recovery in the client's natural environment? And the role of the client changes dramatically within this new framework. This is where we shift power to the individual receiving services. In an acute care model, he or she is treated as the biggest obstacle to his or her own recovery. I remember parroting in treatment, my own best thinking got me here. And he or she is dependent upon an expert for treatment planning and evaluation. In a recovery-oriented system or service, the client drives the bus with somebody else. That's pretty much how they phrased it. She must become an expert on her own condition and management. She is included in service planning and evaluation, and the system or service involves peers and family members in policymaking positions, volunteer, and paid service roles. And because of the shift in power, the service relationship changes dramatically. Under an acute care model, the service relationship is often hierarchical, highly time-limited, and highly commercialized. And in recovery-oriented services, those are marked by a lower power differential between the individual and the care provider, by more time-sustained relationships that are responsive to a person's recovery process, and there's an emphasis on continuity of contact. As a result, the relationship is more natural feeling to the individual, and she's likelier to view her provider as a teacher and an ally. But this shift comes with challenges. Some of them are historical and conceptual. Substance use and behavioral health treatment was created in the image of acute care models they derive from the hospital models or hospital settings and relevant accreditation standards. Biopsychological concept versus biopsychosocial. So, if addiction is about the interaction between a brain and a drug, then a lot of what we do now, what our system would be working. But with a biopsychosocial view of addiction, which is a little more comprehensive and true, much of what our systems offer are not enough or even harmful from the outset. The acute care model is measured in numbers of days and sessions, and often with a predetermined end date, and is often, that's driven by financial factors. Acute care reimbursement schemes drive a lot of what we do in behavioral health and addictions treatment. And responding to complex, chronic, and changing needs across time is very expensive, or can be if we're using clinical care. Can you all think of other challenges to implementing a recovery-oriented framework of service delivery? And I'll let you type some of your thoughts into the Q&A box. in your service setting, how might implementing a recovery-oriented and chronic versus an acute model of care be challenging? Housing. Unwillingness to change the status quo.
And Dean, some participants are dropping in their answers in the chat panel too, so you might want to look at that.
Yeah, that's where I am now. Thank you. Funders need to support the model and not limit sessions and measure successful outcomes only by abstinence. Problem I see is that clinicians are threatened by the change. Administrations fear the loss of funds. Many old 12-steppers won't embrace new pathways. And then somebody else had asked, where does AA and other support groups fall into this model? They fall very naturally into a recovery-oriented system of care. They are just not the primary deliverers of recovery support that people are funneled to after treatment. That's the model that that served me, and it served me well. Just on a personal note. But by and large, that the 12-step fellowships taking such all the responsibility hasn't served most well. All right, well, thank you for your comments. So other considerations for implementing a ROSC, many with substance use disorder experience less severity and resolve problems themselves. It's what's called natural recovery, kind of the unwitting pathway of probably a majority of folks with substance use disorders. Many people with SUD engage treatment and recovery services with high recovery capital, which is a term that we'll explore a lot more, and need few or less intense interventions in order to recover. We can waste time and resources and even create more problems for people by insisting that somebody accesses a higher level of care than they need. So we should use all available tools to gauge problem severity and recovery capital to match appropriate interventions and supports. And importantly, we should center the individuals in decisions about appropriate interventions and supports, like ask, what do you need? Let me show you a range of options. So we will take a break here. Is that okay, Leanne?
Sure, that's fine. We can go ahead and take our 5-minute break now, which means it's about 10:45, so we can come back sharp at 10:50.
Okay.
Thank you.
All right, see you all in 5.
Welcome back, everyone. We're going to go ahead and get started again. And just as a reminder, we will be providing a copy of the presentation to everyone within 5 business days after the event. Now, Dean, if you are ready, we can go ahead and get started.
Sure. I thought that was an appropriate place to take a break because we have covered a lot, and thanks so much for everyone hanging in there with me. So now we're going to talk about patient-centered care. I mentioned centering the individual, and like recovery-oriented systems of care, this is also a concept that comes from the 1990s, and even in the reimbursement schemes for medical care when patient satisfaction surveys were introduced. And actually, I think in one of your resources, one of your handouts, is essentially a patient satisfaction guide for behavioral health. But patient-centered care was really originated in more medical settings, hospitals. So though patient-centered care doesn't have a universal definition, former administrator of the Centers for Medicare and Medicaid Services, Donald Berwick, proposed a definition in 2009, long after the concept was introduced and somewhat implemented, mostly in hospitals, and even suggested adding family to the center of decision-making and access to care. So the experience, to the extent the informed individual patient desires it, of transparency, individualization, recognition, respect, dignity, and choice in all matters, without exception, related to one's personal circumstances and relationships in healthcare. Here are some of the maxims that he proposed. The needs of the patient come first. Nothing about me without me, and every patient is the only patient. And in Berwick's work, he also notes several policy changes that would need to take place in order to implement systems-wide patient-centered care. Can you imagine any policies at your organization that would need shifting in order to provide care around these maxims? And I'll give you a minute, and I'll read some of your comments. So again, can you imagine any policies at your organization that would need shifting in order to implement these maxims in service delivery or honor them? Somebody says, all policies that are related to patient-client care. Somebody says, too many to list. My organization applies the first one. Don't understand the second one. Third one applies. So nothing about me without me was kind of the mantra for folks with disabilities in the 1980s, advocating for policy changes that affected them, more funding for programming for them, and more rights as people with disabilities. Primarily physical disabilities. And this has been adapted, this has been carried by the recovery community in a recovery movement over the last 15 years or so. And that, please do not create policy that affects me without including me, having me at the table, and not just as a token. And that can be at the macro level, we now see a lot of folks affected by addiction, whether it's family members or individuals who struggle with substance use disorder themselves, testifying at congressional bill hearings, Senate bill hearings, actually writing bills alongside their local senators and Congress people, and it can happen on the micro level, where your board of your SUD or behavioral health organization is going to have some composition that includes people who are affected by whatever disorder you treat. And that, down to the super micro level, individuals who are receiving care ought to be involved in decision making around the care that they receive. At this point, I don't foresee any policy change since we focus on patient-centered care and individualized care. Right on. All right, so I'll move on. Thank you so much for your comments. So centering the individual in her treatment and recovery planning involves thoroughly gauging her needs and assets so that we can help her to match appropriate supports to her. I mentioned earlier the term recovery capital. And recovery capital is the measurable breadth and depth of internal and external resources that can be drawn upon to initiate and sustain recovery from severe mental health and substance use problems. And there are 4 categories of recovery capital. One is personal and can be divided into physical and human capital. A person's physical recovery capital includes physical health, financial assets, health insurance, safe and recovery conducive shelter, clothing, food, and access to transportation. Human recovery capital includes a person's values, knowledge, educational or vocational skills and credentials, problem-solving capacities, self-awareness, self-esteem, self-efficacy, which is self-confidence in managing high-risk situations, hopefulness, optimism, perception of one's past, present, and future, sense of meaning and purpose in life, and interpersonal skills. Family and social recovery capital encompasses intimate relationships, family and kinship relationships, perhaps their family of choice, and social relationships that are supportive of recovery efforts. Family and social recovery capital is indicated by the willingness of intimate partners and family members to participate in treatment, the presence of others in recovery within the family and social network, access to sober outlets for sobriety-based fellowship and leisure, and relational connections to conventional institutions like school, workplace, church, and other mainstream community organizations. And lastly, community recovery capital, which encompasses community attitudes, policies, and resources related to substance use and recovery that promote the resolution of alcohol and other drug problems. Community recovery capital includes active efforts to reduce substance use and recovery-related stigma and discrimination, visible and diverse local recovery role models, a full continuum of substance use treatment resources, recovery mutual aid resources that are accessible and diverse, local recovery community support institutions like recovery community centers or sober clubhouses, treatment alumni associations, recovery homes, recovery schools, recovery industries, recovery ministries and churches, and sources of sustained recovery support and early reintervention, like recovery checkups through treatment programs, employee assistance programs, professional assistance programs, drug courts, or recovery community organizations. And this is the last one, I'm sorry. Cultural recovery capital is like community capital, it's a form of it, and it constitutes the local availability of culturally prescribed pathways of recovery that resonate with particular individuals and families. Examples are Native Americans recovering through the Indianization of AA, or the Red Road and Wellbriety movement, or African Americans recovering within a faith-based recovery ministry or within an Afrocentric therapeutic orientation. And evaluating recovery capital involves several domains. So career and education, leisure and recreation, independence from legal problems, employment and financial independence, drug and alcohol recovery, relationship and social support, medical health, mental and spiritual wellness, mood and confidence and problem solving, and treatment and recovery support. So this is a little more comprehensive than the national outcome measures that some of us are used to reporting on to show that our programming is successful, honoring the whole health of the person and the realities of their, the context in which they are trying to recover. So William White crafted a recovery capital point scale, and that's another handout that's available to you through this webinar. And many in community-based recovery services use this point scale with their participants today. And it's how they measure, they may report this to their funders, but it's really about helping in a recovery coaching setting, like helping the client or the recoveree to kind of measure their own assets and needs. This is assessed collaboratively with the individual, and it can help to establish a baseline for where they're at. And taking the survey repeatedly over time can help the individual to monitor their own progress and gain a positive perspective when comparing to their baseline. So that scale expanded, you note your final, you tally your final score, and then list where you might need, some areas of improvement. So Bill starts off with goals for the following year, as you see here, but many who use the tool use it to establish shorter term goals, like over a week or even a day. And out of this survey, Bill designed a crude recovery plan template. So the process of evaluating recovery capital is continuous. It starts with taking, this little survey, the recovery capital scale, developing a recovery plan out of that, in which goals are established. You might, in the manuals for the Recovery Coach Academy, I think it's a max of, well, it might be 5 goals, but a lot of organizations, especially in kind of first interactions with folks who are receiving recovery coaching services, they start out with like 3 main goals at the most, and then they're helped to devise strategies and individual activities, like who else needs to be involved to achieve these. You see them again, you evaluate their progress, and then you reevaluate their recovery capital scale. And it can be incredibly empowering for individuals who partake. And recovery wellness planning is continuous too. Recovery plans are developed by utilizing recovery capital and client choice as bases for goal setting. They're developed largely by the client. The plan walks away with the client. So, you know, even if I, as a recovery coach, may keep a copy with the person's consent, there's really no reason for me to. In fact, I may be asked not to do that, so that if I'm subpoenaed, I don't have anything to produce, except that maybe I met with this person. And continuous recovery planning is the cornerstone of recovery coaching. And this type of planning doesn't have to be formal at all. Here's a recovery wellness plan from a recovery community organization that I worked with in New Hampshire called The Shed. And they work predominantly with the housing insecure population in their like remote area in the sticks. So planning really had to suit the realities of their service population who, you know, were generally very poor, might be looking to use the shower as much as recovery coaching services, and might just like have pockets instead of a place to keep folders, such that they would actually bring it in the next time you see them. And participants at the Shed might jot down a goal at a time with a brief action plan in conference with their recovery coach. And this particular recovery plan doubles as an incentive program when a recovery, which is like the client, wants to use the shower or go on a paid group trip or enjoy other privileges with the RCO. And when somebody completes their goal, the recovery plan becomes a shed buck that they can redeem with their coach or their director. So looking at this recovery plan, can you imagine what the focus is in the client-provider relationship? I'll give you 20 seconds to provide your answers. Looking at this little business card recovery plan, can you imagine what the focus is in the client-provider relationship? Is a good one. Being able to serve as many people that need services in a time-lengthened model of service. Oh, that might have been earlier. It's a good answer for this, though. Responsibility on the person for their own recovery. Somebody else said commitment, retention, so when I first saw this, I said, well, this is genius. And to me, it makes it really clear that the focus of the relationship is on the relationship. It's that we're not gonna meet people from across the desk and talk about their deficiencies and what they need in order to just do better in life. It's like very conversational, often outside on a picnic table or at a local park or off-site while making some food together at the center. it's the focus is the relationship is what struck me. And how about its design? What's the focus in the design? And I'll just provide you my answer, which was the client. It was about let's suit our service to you, which is incredibly effective. And so, I keep in touch with this organization, and they say the results of switching from just like a 8.5 by 11 sheet with a little folder for a recovery plan. Switching to this increased engagement. People were really excited about using these as shed bucks, and they do, and they are proud of themselves when they complete tasks that support their own recovery and are able to kind of be rewarded for that. And they actually are able to keep their plans because they put it in their wallet, in their back pocket or whatever, and it's still there the next time they meet with a coach. So highly responsive to the service population. So we'll compare models of recovery planning. So a medical model involves a diagnostic battery prior to participation. The focus is on alcohol, drug, medical, and psychiatric health needs, and rarely includes job skills development or house searching. Treatment plans are created by a professional team and signed by the client. 25% to 40% of provider time is spent on documentation. And if I could hear you all, I'm sure I'd hear some knowing chuckles. And discharge dates are determined by the clinical team. On the other hand, and this isn't a judgment, this isn't meant to say that there's no place for a medical model for in the care of people with substance use disorders or severe mental health disorders. Of course there is, but in thinking about recovery the way that we do now, it is clearly insufficient, but enough of my editorialization. So in a social model of recovery planning, diagnoses are not required for participation. A client is responsible for the development, revision, and implementation of their recovery plans each week, month, or phase of their participation or stay. Staff, volunteers, and peer residents play guide and teacher role in the planning and monitoring process. There is minimal documentation, and discharge dates are undefined or decided by or in collaboration with the client. So again, I'll turn it over to you. What is the biggest difference between these two models? This may be a trick question because we just listed a lot of the differences, but what strikes you about the differences? What might be the biggest in your head? I'll give you about a minute. The one comment is that, oops, I lost it, sorry. recovery from, oh, I'm sorry guys, I'm not able to scroll up or down, so as soon as they come, they're gone. Recovery is reconnecting with yourself, taking care of yourself. That's from much earlier, I'm sorry. Oh, here we go. The medical model is professional-led and has time frames, and the social model is individual or peer-led with no time frames for beginning or end of treatment. Medical is professional-driven, social is more client-driven. Medical model is the client being told what to do, and the social model, they have a hand in their treatment. Yeah, so you guys see what I see. And you know, what strikes me in comparing these two models is that one is intended to serve people who are incapacitated, and the other is intended to serve people who have agency. One is kind of disengaging, the other kind of suggests a high degree of engagement. And in recovery coach trainings, we talk about treating people as either objects, recipients, or resources. And when working with people who have some agency, which is the majority of us, even at our worst, there are few justified reasons to approach their care as if they were objects, which is to say, you know, I'm treatment planning at you. This is the way it is, and this is what you're going to do. And if you don't comply, then you know you're going to be packing. And we tend to get really bad results when we use that approach with people with mental health disorders and substance use disorders. So I've mentioned recovery coaches, so I'll describe them. Peer recovery coaching is not a standardized service, and recovery coaches can work in a wide variety of service contexts like jails, hospitals, treatment programs, community centers, and street-based programs. And some of the characteristics of a recovery coach are that she often has lived experience of substance use disorders and recovery from them. And their training and application are mostly in a community-based setting like recovery community centers while working or volunteering with a recovery community organization, which I'll describe pretty soon. And so when we hear the term recovery coach, different service roles may come to mind. William White and others developed a role clarity matrix that is intended to differentiate the recovery coach that I'm talking about from other kinds of roles. So in this matrix, the recovery coach I've been referencing is in the first column under peer recovery support specialist. And I'll try to summarize these as I read them. So other titles for PRSS is a peer specialist, recovery support specialist, recovery guide, substance use counselor, obviously, drug and alcohol counselor, clinical case manager, and then the professional recovery coach, which can often be confused with the recovery coach in a community-based setting working for an RCO, is also called recovery coach, recovery life coach. And often, you know, they're kind of advising on somebody's business strategy, but sometimes they're talking about, you know, recovery for mental health and SUDs. The primary purpose of the peer recovery support specialist is to promote long-term substance use recovery, with recovery being the most being frequently defined in terms of sobriety or remission. Still, that is the case, a substance use counselor is a very clinical role, using a medical and or a social model, and emerge within the professionalization of substance use treatment and being encompassed within present integration of behavioral health. And then the professional recovery coach, the primary purpose of the role is about transformation. You've probably heard of transformation coaches. The nature of each role for the PRSS, it's non-clinical, recovery model, emerged out of grassroots recovery community organizations and expansion of recovery support services. The substance use counselor is about achieving personal, family recovery, with recovery defined in terms of post-treatment, abstinence and social function, healing and resolution of related traumas, issues, and blocks, which really both of the other recovery coaches don't or shouldn't be touching. And then the professional recovery coach is also non-clinical, non-diagnostic, supporting multiple pathways to recovery, and the focus is on personal transformation. Relational model for the PRSS, so the client-provider relationship is non-hierarchical, although there is a noted, kind of power differential between the two. One is probably in a better spot in their lives and perhaps their recovery than the person that they're meeting with. But they're really the coach is using his or her own experiences, is allowed to tell their own story, identify as a person in recovery, and uses their testimony to the reality and power of recovery to kind of serve as a role model. Substance use counselor often isn't allowed to do any of that. It's professional, hierarchical, highly commoditized and commercialized. And with a professional recovery coach, they are essentially equals. It's usually a business relationship in that, I will pay you, or my parents will pay you this much money to retain you for these hours. It's usually kind of time limited. And the client is the experts on themselves and at choice, and the coach brings their expertise in communication. And as a change agent, the emphasis is on supporting, challenging, and especially on accountability. The recovery philosophy is very much like for the PRSS. It's very the same as the above, the previous slide, talking about the relational model. The recovery philosophy is their relational model, but their philosophy includes the added role of advocate, and that's advocate with a capital A, to shape pro-recovery policies and practices in the community. The substance use counselor tend to view recovery as something that happens inside the client. There's not a lot of focus on kind of external conditions and breaking the person-drug relationship, modifying the client's perceptions, thoughts, and actions. And in the professional recovery coach, their philosophy that they may view recovery as naturally attractive and occurs when the client is in touch with the outcomes that they want in their life. Again, this kind of transformation idea, and has ongoing support and accountability in their capacity to be successful. Support across the stages of recovery for PRSS may include collaboration with substance use professionals on recovery initiation and extends beyond to include pre-recovery transition between recovery initiation and recovery maintenance, transition from recovery maintenance to enhanced quality of life and long-term recovery. With the substance use counselor, the primary focus is on recovery initiation, biopsychosocial stabilization of persons committed to sustained abstinence, and there have been recent calls to integrate harm reduction perspectives within the role. With a professional recovery coach, supportive stages of recovery looks like they might work individually or as part of a team, supporting multiple pathways of recovery across all stages from pre-recovery to long-term. Supports the client's choice of where to begin, what to work on, and vision of desired outcomes. Recovery goals with a PRSS there's a focus on removing obstacles, barrier reduction to recovery, and building personal, family, and community recovery capital to support long-term recovery. With a substance use counselor, the primary role is in facilitating the process of recovery initiation for those who have reached a point of readiness to change. Recovery goals in the professional recovery coach relationship, the focus is on facilitating self-understanding and a higher level of functioning and performance, helping the client to achieve their life, business, and recovery goals more easily than they would on their own. Recovery planning framework, so how they create recovery plans and maintain them with the PRSS. The PRSS facilitates the development of a person-driven recovery plan, which is much broader in scope and more community and recovery focused than traditional treatment plans. With the substance use counselor, they use general assessment data to generate a professionally directed treatment plan and make diagnoses and probe on undisclosed issues. So tell me more. And with the recovery coach, professional recovery coach, they facilitate the development of client-driven goals and plans based on their stated outcomes, and facilitates the skills needed to achieve them. It's broader than abstinence to include lifestyle and vision of success. Or to describe the activities of the PRSS are identify, engage, encourage, motivate, share, express, enhance, orient, help, link, and on. With the substance use counselor, words would be diagnose, treat, assess, screen, refer, document, counsel, pathology. With a professional recovery coach, they coach, they facilitate, they converse, co-create, partner, inspire, brainstorm, clarify, challenge. The education and training for a PRSS.
Hey, Dean, can you hear me?
Oh, hello?
Yes, Dean, this is Leanne. Just be advised that your audio seems like it's getting a little less clear. I'm not sure if you're doing anything a little different, but I just want to let you know.
Okay, thank you. Is this better?
Much better.
Okay. So the education and training for PRSS, their credibility springs from experiential knowledge. They are, the service is really meant to provide connection, personal and practical connection to sometimes hard to reach populations, and kind of the hook is that I have experienced what you have experienced. And so personal experience in recovery is not necessarily required to fill this role, but it's certainly a plus in engaging peers. Certification status for peer recovery support specialists varies widely by state. So most states have something. In New Hampshire, it was a CRSW that could be applied for treatment settings or in community-based settings like in recovery community centers. Right now I'm in Texas, where they have it split into two kind of credentials, a PRS and, well, it's only been a few months, so I forget the other one. But it's meant to be kind of applied in different settings. With the substance use counselor, they're credentialed by experience of formal education and institutionally credential-led via certification or licensure, a little, much more regulated and much more training involved. With a professional recovery coach, you don't really need anything. You can kind of hang a shingle, say I'm a professional recovery coach, and charge what you want. But there are some certification programs that you can go through. Core competencies for a PRSS are knowledge and modeling of core recovery competencies or values, pathways, styles, and stages of personal and family recovery, knowledge of diverse cultures of recovery, ability to navigate service structures of local recovery mutual aid groups and orgs, ethical decision-making, skills in recovery planning, assertive linkage to indigenous recovery supports. Core competencies for a substance use counselor would be knowledge of substance use and skills to perform clinically oriented functions, pharmacology, epidemiology, theories of substance use, screening and assessment skills. And with a professional recovery coach, their knowledge and use of professional coaching skills, understanding or knowledge of recovery and substance use, and additional topics as needed with a given client. Ability to generate possibility and elicit positive change talk. So motivational interviewing is really especially useful for all of these service types, but the recovery coaches probably utilize it more so than the clinician. Financial payment or reimbursement for a PRSS is by design mostly none. Recovery community organizations are meant to be kind of volunteer-based organizations, but there are some paid staff and even paid recovery coaches, especially as single state authorities begin to contract RCOs and therefore they're able to pay staff. With the substance use position, usually paid, and professional recovery coach, it's a paid position with or without pro bono work. I have a friend who does this work, and he did a 10-hour retainer for $3,500. So that role tends to charge a lot. The community-based, the peer recovery support specialist is a free service. Duration of contact for a PRSS is highly variable, with some expected to sustain contact for months and years. With a substance use counselor, obviously much short term, with a usually predefined beginning, middle, beginning and end, and becoming more brief as the payment schemes, become more unsettled and or cut. And with a professional recovery coach, duration of contact is maintained until goals are achieved or as long as the client wants or needs coaching. Service delivery area, so the setting for delivery of recovery coaching from a PRSS is in the person's natural environment when possible. Linking people from treatment institutions to indigenous communities of recovery. Support is delivered as close to possible to the person's natural environment. So, recovery community centers that would house and employ that kind of recovery coach, they're really looking to get hang a shingle on Main Street. The idea being that, recovery support has often occurred underground, figuratively, sometimes literally, in church basements, and that we really need to make recovery noticeable and accessible to people, and we want our center to be, somewhere right in the middle of town where people are. With the substance use counselor, it's usually in a treatment center or, in their private office. And then more and more kind of that telehealth model so people can access treatment through their phone or computer. And with a professional recovery coach, they meet with the client in person or by telephone, typically for international clients meeting by Skype, phone, or email. Linkage to local recovery communities of recovery for a PRSS type of recovery coach. Direct communication with indigenous recovery support organizations with an emphasis on orienting and assertively guiding individuals into engagement with communities of recovery. The substance use counselor, there's variable levels of communication with indigenous recovery community orgs. Passive referral, which would be verbal encouragement with possible provision of a meeting list, is dominant pattern, and there are growing calls for more assertive linkage procedures. With a professional recovery coach, there's minimal or indirect communication with indigenous recovery community organizations. The client is coached to find and connect with resources, including local or online communities of recovery, and it's useful for those areas with few services or for additional recovery pathways or options. So I've mentioned a lot about recovery community organizations, and I'm sorry I just read a bunch of slides to you. I think, and certainly, the authors of that thought it was incredibly important to differentiate, the peer type of recovery coach from other roles, because it is a pretty new service. The kind of foundational recovery coach training, which is a 30-hour training called the Recovery Coach Academy. That was only written 9 years ago. And it's been mostly in the last 5 or so years that recovery community organizations that employ recovery coaches have been developed, and starting to see some results of their service type. So it's really no wonder that that this isn't really a commonly understood role, and the recovery community organization isn't commonly understood either. So an RCO is an independent and nonprofit organization that's led and governed by representatives of local communities of recovery. There is an accreditation for this organization type or for the peer recovery support services that they offer. And the requirement is that their governing board is at least 51% people who are in recovery, which includes family and descendants. RCOs organize recovery-focused policy advocacy activities, carry out recovery-focused community education and outreach programs, and or provide peer-based recovery support services. They involve the entire recovery community, which includes people in recovery, their families, friends, and allies, including recovery-focused substance use and recovery professionals, organizations whose members reflect religious, spiritual, and secular pathways of recovery. And their mission, more often than not, is to mobilize resources within and outside of the recovery community to increase the prevalence and quality of long-term recovery from alcohol and other substance use. Public education, policy advocacy, and peer-based recovery support services are the strategies through which this mission is achieved. Can anybody name the active RCO in their community if they have one? You can use the Q&A box. Usara. NAMI. NAMI would be for certain a mental health focused RCO. I hadn't thought of them that way, but yes. Oh, and somebody asked, what is the accreditation called? It's called the Council for Accreditation of Peer Recovery Support Services, CAPRS, which is a part of Faces and Voices of Recovery. Oh, I lost my scroll function again. Yeah, Rebel Recovery in Palm Beach. That's one that I noted in the next slide here. So they came on my radar because they started incorporating syringe services delivery, and researchers studied the positive results of them doing so. So I'm a nerd for that stuff. So they operate out of West Palm Beach. But to my understanding, Florida doesn't have kind of a large network of RCOs the way that many other states, particularly in the Northeast, have, but only really in the last 5 years or so. So that is why I focus so much on this kind of service type and organization type, because, we've noted a lot of challenges in implementing kind of recovery-oriented principles and service delivery in the organizations that you may work or in the settings that you work. And so supporting the development of this kind of organization and community-based service type can probably help you in your own service delivery and in those warm handoffs and making sure that people have that connection during treatment or while they're engaged with your service, sometimes in lieu of, and certainly afterwards. The RCO tends to fill a lot of gaps in the continuum of care for people with SUD. And so I know Faces and Voices of Recovery. I'll say that the National Recovery Institute that contracts me and had me do this webinar, they are a wonderful resource. They're a national RCO that focuses less on direct services and more on national policy and recovery-focused training like this one. And the association, somebody had written them as an RCO. They're a collective of RCOs and called ARCO, and they are also essentially a program of Faces and Voices of Recovery. So thank you so much for hanging in there with me and exploring this topic with me. That was actually several topics, but I hope I covered them well enough for you to continue exploring.
Dean, thank you so much. I think that we're ready for me to take control back of the presentation.
Sure.
If you're ready, I'll go ahead and do that.
I am ready.
Great. So I just want to remind all of our participants today that when I conclude the webinar in just a moment, your browser is going to take you to an evaluation on FADA's website. And if you want to receive a statement of credit for attending this event, do please complete the evaluation for us. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE Broker for Florida licensed healthcare practitioners, do please provide us with an accurate Florida Department of Health license number the first time that you register with us. And then after you register or sign in, you'll be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up your profile in FADA's system. This just helps us connect your attendance with your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today, probably in about 30 minutes, if not sooner. The sender will be Messenger at WebEx. Do remember that the evaluation will close at midnight on Friday, December the 7th. Also, do be aware that we do not email statements of credit. Instead, after we verify your attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. So in conclusion for today, Dean, thank you so much for sharing your expertise with us. We very much appreciate it. And I'd also like to thank all of our attendees for joining us today and listening in and contributing and participating so much today. Finally, we'd also like to especially recognize and thank the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's education. So in closing, have a great rest of your day and hold now for the evaluation. Thank you, everyone.